The challenge of the abdominal examination is the accuracy of physical signs. There can be a fair number of physical signs in the peripheries that you must identify. In the abdomen, both masses that are too small or too large pose difficulties of their own. We will now demonstrate the abdominal examination.
Good morning, I'm Dr. Koh.
Good morning.
May I examine you today?
Of course.
Can you roll up your pants for me? Thank you.
You may at times be able to identify from the foot of the bed whether this is a renal, hepatobiliary, or hematological case. It is important to look at the patient whether you may even be able to identify the presence of an organomegaly from the foot of the bed. Ensure that you have adequate exposure, particularly ensuring that the patient's pants are brought down to the inguinal crease so that you do not miss the transplant scar.
Can I have a look at your hands, please? Can you do this for me? Yep. Okay, and cock your wrist up. And turn your hands around. Okay, you can relax your hands. I'll just have a look at around the area. Okay.
Another area that's commonly missed is the forearm and the upper arm, in which area you may find the presence of dialysis fistulae. Additionally, in the neck region and the supraclavicular region, you may find scars suggesting an old tunnel catheter insertion, as well as the parathyroidectomy scar in the neck.
Okay, I'm going to be looking in your eyes. Can you remove your spectacles for me? Okay, and pull down on one of your eyelids. Okay, that's good. You can wear your spectacles again. Can I look into your mouth? And open your mouth for me.
In the face region, the eyes are critical. Spend some time here. Look for conjunctival pallor as well as sclera icterus. You cannot afford to miss these two signs.
Okay, I'll just be looking at your chest. Okay, do you have any pain in your tummy?
No.
I'm going to be feeling your tummy, okay?
Okay.
Just a bit deeper now. Okay, deep breath in for me. And out. And in. And out. And in. And out. And in. And out.
As you palpate for the liver, start from the right eyelid fossa so as not to miss a very large liver. Go upwards to the costal margin and then medially into the epigastrium. Certain patients have an enlarged left lobe of liver, in which case the mass may only be epigastric. And if you stop at the costal margin, you may miss an enlarged left lobe of the liver. If you identify a dull percussion node in the right hypochondrium but did not palpate a liver, try to palpate again because you may have missed a small liver. If you do find a palpable liver, you will want to measure the liver span with a ruler or tape measure. You will do this by first percussing to identify the upper border of the liver. So this is the area of dullness, this is the upper border of the liver. I will leave my finger here. With the other hand, I will palpate for the lower border of the liver. Take a deep breath in, sir. Okay, deep breath in and out. Again, this is your chance to palpate again if you haven't gotten it right the first time. Okay, suppose this is the lower border of the liver. Leave both fingers here, and this is my liver span.
Can you take a deep breath in for me? And out. And in. and out, and in, and out.
When palpating for the spleen, start from the right eyelid fossa. Splint the spleen with the left hand. And in certain cases, you may also wish to roll the patient slightly towards yourself. Do not stop at the costal margin, but go a little bit laterally. In this case, some spleens enlarge inferiorly rather than inferior-medially.
Can you roll over this side for me?
Keep your finger at the same spot. Do not move the finger as the patient rolls over. If you find that there is a positive shifting downwards, meaning that your percussion note has now changed from down to resonant, you can confirm this by percussing downwards now into the umbilical region and seeing where your percussion note changes from resonant to down, and then flipping the patient over, at which point the percussion note will be resonant again. You may also percuss for throat space in this position.
Can you lie back down for me?
Many candidates find difficulty ballotting the kidneys. The first and most important step is to recognize that the kidneys are not first identified on this step. They are first identified ideally at the foot of the brain, in the peripheries, but failing that, on the deep palpation. You may not feel in certain cases a clear mass, but what you will feel is a fullness in a certain region. And what you do when you ballot for the kidneys is to confirm these findings. The kidneys are often more medial than you think. They are just barely 2 cm to 3 cm away from the aortic and the inferior vena cava region. And you should not ballot too laterally, in which case you may only ballot the lateral abdominal fat. So it's actually quite medial. With the other hand, the non-ballotting hand, you need to ensure that you are deep enough behind the back and not just superficially here, just behind the back. Flick upwards while pressing downwards with your palpating hand, and you may feel a ballotting mass if a kidney is present. If you do not feel it at one spot and you strongly suspect that a kidney is there, you may wish to move your position slightly and ballot at a slightly different position. This technique will help you to improve the sensitivity of palpating and ballotting for the kidney.
Can you sit up for me? Okay, I'll just be feeling the glands in your neck.
Inspection of the back is equally important, and the key signs that you don't want to miss are the presence of any bone marrow aspiration scars, which will give you a clue that this is a hematological abdomen.
You have any pain in your legs?
No.
I'll just have a quick feel. Okay, thank you very much.
Thank you.
A final note. Some candidates find difficulty with a very large abdominal mass. If the mass is very large, it can be difficult to distinguish liver or spleen from kidney because a very large mass often displaces overlying bowel such that the percussion note becomes down over the mass. You may not always be able to get above the mass or below the mass if it is too large. Some tips to distinguish the mass when it is very large are as follows. First, the presence of downers to percussions in throat space, which is over here. If throat space is resonant, this is unlikely to be a spleen. But if throat space is down, it is unlikely to be a kidney and most likely a spleen. Second, the outline of the mass. A mass that crosses a midline is unlikely to be the kidneys because they tend not to cross the midline, they are retroperitoneal organs. A mass that crosses the midline is more likely to be a liver or a spleen. If the outline of the mass is nodular when you palpate it, then it is likely to be a liver or a kidney, not a spleen. On the other hand, if you can feel a clear-cut notch, then that is the hallmark of a spleen. Finally, if you have a very large mass and there are no signs of renal replacement therapy, then a kidney becomes less likely because very large polycystic kidneys are likely to have failed. One last thing that we did not demonstrate in this video is the palpation of a renal allograft. If you identify a scar in the iliac foci, it is important to palpate and see if there's a renal allograft beneath that scar. Do not assume that a renal allograft is always present, as a similar looking scar may be the scar of a hernia operation or a appendectomy, especially for older patients. If you are unable to palpate an allograft beneath that region, try to palpate a little more laterally and sometimes more superiorly, as the position of the allograft can shift a little. This is the abdominal examination.